Hi, good afternoon, one and all. Welcome back to this afternoon session. Glad to see you all. I hope lunch was good. So, what we're going to do now is we're actually going to introduce to you another of my moderators. We had Katharina with us in the morning. My afternoon storyteller is going to be Dr. Fauzia. There you are. Hi, Fauzia. How are you?
Hello, I'm fine, thank you.
Hi. So, Dr. Fauzia Khan, we are really happy that she could join us today. Dr. Fauzia is actually one of the founding members and the past chairperson of the Department of Anesthesiology at the Aga Khan University in Karachi, Pakistan. Her current clinical interest is in pediatric and neurosurgical anesthesia, and she's particularly interested in perioperative pain management and assessment in pediatric patients. She's widely published and has published more than 160 articles in peer-reviewed journals. Good to have you here with me to tell Little D's story, Fauzia.
Thank you very much, Angela, for this nice introduction. And welcome to all of you this afternoon. We are going to continue the pediatric pain session. And we will continue with the story of little D. Let's look at the next slide in the story. Yes. So we move on to the oncological plan. After a thorough discussion, her doctors and parents realized that little D's best chance for survival was a life-changing surgery. And they needed to amputate her leg. "Will I be in terrible pain after the surgery?" She whispered to her pain doctor. "Not if I can help it, my dear," said her doctor resolutely. "I have a plan." So before I introduce the first speaker of this session, just to let you know that we'll have the question answer session at the end of this presentation. But if you can keep sending your questions in the chat box. The first speaker who's going to talk about the challenges and benefits of regional anesthesia in the oncology patient is Dr. Anjali Koka. Dr. Anjali Koka is a practicing pediatric anesthesiologist and pediatric pain medicine physician at the Boston Children's Hospital, Boston, Massachusetts. She completed her anesthesia residency training at Massachusetts General Hospital and her pediatric anesthesia fellowship from the Boston Children's Hospital and also another combined program. She specializes in regional anesthesia and perioperative pain management, and she's the program director for the combined pediatric adult pain medicine and fellowship at Boston Children's Hospital. As I said, Anjali is going to talk to us about challenges and benefits of regional anesthesia in oncology patient. Anjali.
My name is Anjali Koka. I'm a pain physician and anesthesiologist at Boston Children's Hospital, and it is my pleasure to be invited to speak to you today. I'm going to speak about the challenges and benefits of regional anesthesia in the pediatric oncologic patient. I have no disclosures. Today, we're going to talk about the perioperative goals related to acute and chronic pain. We're going to focus on regional anesthesia for cancer surgery and cancer surgery related pain, but consider other mechanisms of cancer pain. We're going to explore the options for regional anesthesia in infants and children, and we're going to specifically look at several key components when choosing regional anesthesia options. And then we're going to strategize around the perioperative pain management plan. Where are the family and the patient in their cancer journey when we meet them preoperatively? What has been their previous experience? It's important to understand this so that we can understand the risks and benefits and balance those risks for any of the interventions that we might do, such that no intervention is in isolation. When thinking about the biopsychosocial factors that modulate pain, it is important to understand for the individual patient the biology, and that is to understand the mechanism or etiology of pain. Is the pain tumor-related pain? Is it cancer therapy-related, or is it surgical? Also, we need to think about the genetic factors that the individual brings, and then think about the psychosocial factors that help modulate pain, so we can understand the context of the patient's pain, understand their coping strategies for stress, anxiety, depression, and then also take a step back and look at the family and the modeling of pain behaviors, the parents' reaction to pain, and then look at the social and cultural conceptualization of pain, pain accommodations, and the social supports that the family might have in place. Chronic post-surgical pain, or pain lasting more than 2 months after surgery, has been extensively studied in the pediatric population. While study results are mixed, the most common risk factors include pre-surgery pain, pre-surgery anxiety or pain catastrophizing, and poor pain coping. Additionally, pre-surgical parental pain catastrophizing has been identified as a risk factor. The second study listed here specifically looked at pediatric patients with extremity osteosarcoma after limb sparing or amputation surgery. They found that the duration of pain treatment was significantly longer in patients resistant to psychological interventions than those receptive to these interventions. Shorter duration of pain treatment was associated with a slightly older age and then receptiveness to the psychological interventions. Let's return to the case of little d. Let's assume she's an 8-year-old girl and has a right distal femur osteosarcoma. We're meeting her preoperatively. She's about 2 to 3 months into her diagnosis. At this time, she's met with numerous physicians and caregivers. She's undergone chemotherapy. Maybe she still has some baseline pain in her leg. Maybe she's taking medications for that pain, such as a neuropathic pain medication or other medications. And those medications might need to be adjusted before the surgery. But she is scheduled for an above-knee amputation, and this is a surgery for local tumor control. We should think about some of the goals of care for this patient. I know that the care team would like her to recover as quickly as possible so that she can move on with her treatment and put the patient in the best position for a quick rehabilitation. So in this case, it's important to think about the types of pain. Somatic and nociceptive pain after surgery is going to be present, as well as neuropathic pain. There also may be cancer-related neuropathic pain or cancer therapy-induced neuropathic pain. So thinking about the central and peripheral pain that she might have, we want to also consider risk factors for phantom limb pain, either due to chemotherapy or pain before surgery. We all know that there are many benefits to regional anesthesia. The physiologically and clinical advantages of afferent neural blockade can include optimizing pain relief and reducing opiate consumption, preventing the transmission from acute or preventing the development from acute to chronic pain, reducing the incidence of post-op nausea and vomiting, reducing respiratory complications, and improving tissue perfusion. by far, the major trend in pediatric regional anesthesia is the use of ultrasound. Our skills have advanced over the past several years, such that epidural catheters are being replaced by peripheral and plexus catheters. For example, paravertebral catheters or erector spinae catheters are commonly used for pain control postoperatively for patients who undergo thoracotomies. Another example would be a lumbar plexus catheter or peripheral catheters for lower extremity surgery. This study looks at the Pediatric Regional Anesthesia Network and contains data from more than 100,000 blocks administered at 20 children's hospitals across the United States. So the PRAN database has over 100,000 blocks documented in it. This study analyzed the risk of major complications associated with regional anesthesia in children. Transient neurologic deficits were found in only 25 cases. That's 2.4 out of 10,000. And there were only 2 cases of sensory deficits that lasted more than 3 months. There were 7 cases of severe local anesthetic systemic toxicity, and most of them involved bolusing of local anesthetics, and they were in children who were less than 6 months of age. Additionally, as the data shows, over 90% of these children had their regional anesthesia placed under general anesthesia. So this confirms the safety of placing blocks in children under general anesthesia. There are many ways to approach pain control with regional anesthesia. And all over the world, it is done in different ways, and people are exploring newer ways for surgeries that they've been doing for a while. The question is, where do we target the nerves along that pathway from the central spinal cord to the periphery? This image shows the innervation of the major bones in the body, and it helps us to think about the surgical site. And it's in addition, it's helpful for specific patients to review the imaging, the MRI, X-rays, and CT scans of the tumor, and then have a discussion with the surgeon and the OR team and the patient and family about the types of regional anesthesia that could be possible. Let's think about this case again in little d. The regional block considerations are numerous. So she is getting an above knee amputation. We want coverage from the spinal levels of L2 to about S3. Her weight is important in consideration if we're doing peripheral catheters. So let's assume she's an average weight of 25 kilos. And then thinking about where she is recovering, in hospital recovery, and then her home recovery and pain control at home. In hospital, regional options are numerous, but they can include an epidural. They can include a combination of peripheral and plexus catheters. When thinking about epidural anesthesia, it's important for kids who have had chemotherapy to review the blood work, look at the platelet count and the coagulations. But more specifically for the epidural, since this is a one-sided surgery, we have to think about how it should be placed. Do we want a unilateral block? Do we want it to be placed by traditional landmark technique? Do we want to use nerve stimulation or nerve twitching while placing it? Will image targeting be helpful by using ultrasound or fluoroscopy to guide the epidural to the right level and to one side of the spinal cord, just to target the side of the amputation? And then thinking about peripheral catheters, do we want one catheter or several catheters? So if we decide not to do an epidural and go with peripheral regional anesthesia, do you want a plexus catheter that could cover the higher branches A lumbar plexus catheter could cover, T12 to L5 on average, or a suprainguinal femoral fascia iliaca catheter could cover the femoral, lateral femoral cutaneous, and maybe additionally the obturator distribution of the nerves. And then what about the posterior leg, the sciatic distribution? Do we want to think about how do we have sciatic coverage? Would an anterior sciatic be sufficient, or do we need it even higher than that? And we can think about a subgluteal sciatic or even a parasacral sciatic catheter. And then what should you do with your catheter? Do you need to tunnel it under the skin so that it's secure in place and that it stays out of the surgical field? Are any catheters going to be in the way of emergent surgical access to vessels? Or are the catheters in compressible space in case there's bleeding? Additionally, we can think about, is she a home catheter candidate? Our hospital has a home catheter program, and kids with peripheral catheters, such as sciatic catheters and even fascia iliaca catheters, are able to go home with their catheters a few days after surgery. Let's think more specifically about epidural anesthesia. The upper picture shows an epidural that was placed under fluoroscopy. The thick line at the bottom is the needle, and that thin line coming out is the catheter, and then you can see dye spread above it. The lower picture is an epidurogram showing contrast through an epidural catheter. And this image shows very clearly that this catheter is one-sided, it's unilateral, which could be very helpful in situations such as an amputation, because it will really bathe those nerve roots on that side to provide a denser block. Several studies have looked at the pharmacokinetics of local anesthesia infusions in the epidural space in the pediatric population. The first study that's listed there shows stable plasma concentration of unbound ropivacaine over time after an infusion of either 24 to 72 hours, and that there was no age dependency after this epidural infusion. So these plasma concentrations were stable over time. The second study looked at the pharmacokinetics of ropivacaine bolus in lumbar epidurals in the pediatric patients, ages 3 to 48 months. And they showed that the pharmacokinetics for bolusing ropivacaine in these lumbar epidurals was similar to adults. Importantly, the drug clearance was less in infants compared to older children. Just looking at some of our specific guidelines at Boston Children's Hospital, when we're thinking about regional anesthesia for children under 6 months of age, in general, whether it's an epidural or peripheral catheter, we use chloroprocaine as our main infusion agent, and we use chloroprocaine 1.5%. If it's an epidural, we do use additives, so we can add in fentanyl or clonidine, and then the usual rates for our younger kids are listed here. On the right side of the screen, you can see for ages 6 months and over, our guidelines for epidural infusions. On average, we use ropivacaine 0.1% and sometimes 0.2%. And again, we can have additives of opiates such as fentanyl and hydromorphone, and additionally, we can add in clonidine. The rates are actually slightly lower for the older children. Let's say we decided for little d not to do an epidural, but to do peripheral or plexus catheters. A good choice for her would be a lumbar plexus catheter. that would cover the upper lumbar nerve roots, and it would be posterior, so it would be out of the way of the surgical field. To cover for sciatic coverage, a good option would be a subgluteal sciatic nerve catheter. This would again be posterior and out of the surgical field and is in a location that is compressible. Additionally, it is an option for us as a home catheter option if she would wish to go home with an elastomeric pump to provide additional pain relief in the days after surgery. Another alternative would be a fascia iliaca catheter, because that's another home catheter option. So we would be able to transition that to providing postoperative pain relief at home. Though our first choice would probably be lumbar plexus for the better, wider coverage that we had talked about earlier. Going into some of the details of providing regional anesthesia in our hospital, you can see our block setup is pretty simple, but we have catheters and then a lot of securing devices so the catheters don't move out of place. We have a BK ultrasound machine, which provides decent imaging. For positioning for the lumbar plexus catheter, the patient is positioned laterally with the operative side up, and our probe is positioned like this on the side of the patient and allowing us to see the lumbar plexus from the side position and approaching it posteriorly from the back to the front, from posterior to anterior. This imaging, it's a little fuzzy, but it does show the transverse process here. The vertebral body is indicated there, and then the psoas muscle is in the middle. This would be our needle path, again, from posterior to anterior. The lumbar plexus, again, is shown here, and this video shows a little puff of local anesthetic that can be seen when we bolus the catheter in the psoas muscle. Additionally, on the right side of the screen, you saw the peritoneum moving. Let's talk a little bit more about the details of a subgluteal sciatic nerve catheter. And it can be approached again in using the patient in the same position that they were positioned for the lumbar plexus. It's just a little bit lower down in the body. So it's easy to do both these blocks in conjunction. We usually use a curvilinear probe and approach the nerve either posterior to anterior, caudad to cephalad, or cephalad to caudad if we think we're going to be in the surgical field. This video shows the landmarks on ultrasound. The ischial tuberosity is on the left, the greater trochanter is on the right, and the sciatic nerve is labeled there. And this shows some dynamic scanning trying to locate that nerve. Just briefly, I wanted to review our intra-op dosing guidelines for these specific catheters. A lumbar plexus catheter, we would bolus it intraoperatively with ropivacaine 0.2%, and with the doses noted there, they're all weight-based. And then if we do multiple blocks, we have to use the combined maximal total dose for those blocks. And again, just for your reference, when you look back at the slides later, I've included our dosing guidelines intraoperatively for most of the common blocks that we place at Boston Children's Hospital. Postoperatively, our catheter infusions usually run ropivacaine 0.1% or 0.2%. And again, we have maximum rates. They're all weight-based, and if patients have multiple catheters, we have to use the maximum combined rates to prevent toxicity. Monitoring of patients with local anesthetic infusions. So if you have a continuous infusion of local anesthetic, you're assessed every 4 hours with vital signs, pain assessment, responsiveness, and then you're assessed for signs and symptoms of local anesthetic toxicity. Your catheter dressing site is also assessed every 4 hours. Every hour, we like to assess the respiratory rate and depth of respiration. This is especially important with epidurals that may have opiate in them. And urgent responses are required for patients who have pain that's not consistent with surgery or inadequate pain control. And then obviously, if you have signs and symptoms of local anesthetic toxicity as those listed here, that would be something to evaluate closely. Respiratory depression requiring intervention, a decrease of greater than 20% in blood pressure, and then signs of infection. Again, if the catheter tubing is disconnected or the site is exposed or there's an inadvertent displacement, this is also something that needs urgent attention. So let's think about our case again. What if little d had a right femur DVT and was on a apixaban? So she has a DVT in the leg that had the amputation, and she was readmitted for pain control and for a likely revision of the femur. What would be our considerations for regional anesthesia? The location of the DVT in the femur might prevent us from placing a femoral or anterior sciatic catheter. We would have to hold the apixaban for at least 48 hours before placing a deep plexus catheter. And our options might again include the lumbar plexus because it's posterior, and then a subgluteal sciatic because we'll get good coverage with both those catheters. And again, the subgluteal sciatic catheter is in a compressible space. This slide briefly shows our Boston Children's Hospital neuraxial and deep plexus guidelines for anticoagulation. Our definition of a deep plexus catheter or a deep block is a block that's in a space that is not easy to compress. That would include the paravertebral space, the lumbar plexus space, the fascia iliaca, supra and infraclaviculars, and parasacral sciatics. These next few slides are just for reference when you go back and look at the lecture. And the important thing to take away is that the dose of the medication is more important than the dosing interval. So if there's a higher dose of a prophylactic medication, you might require longer wait time before catheter placement or manipulation or removal. This again is talking about warfarin and other anticoagulants. There are no contraindications with aspirin or with NSAIDs. Direct and indirect 10A inhibitors have their own specific guidelines, and we follow the European Society of Anesthesia and the ASPA guidelines for those blocks when they're on these anticoagulation agents. Just for reference, I've included the European Society of Anesthesia recommendations, and again, they've worked closely with ASRA to construct a single set of guidelines. There are some examples of deep plexus catheter hematomas that have been reported. Most have been in patients who had perioperative anticoagulation for various reasons. The sciatic and femoral nerve blocks have had bruising and hematomas associated with them, as have the lumbar plexus, and you can have a large retroperitoneal hematoma. The most interesting thing about these cases is that the blocks were difficult to place, so difficult placement, multiple attempts, does increase the risk of hematoma. I just wanted to highlight some of the programs that we have here at Boston Children's Hospital, and one of them is our transitional pain clinic. It provides a comprehensive preoperative pain management assessment for kids who are having surgery, and they're able to meet with a pain physician and anesthesiologist to discuss the goals of the surgery and the perioperative pain management plan. Additionally, they meet with one of our pediatric pain psychologists to learn and review and practice pain coping skills that they can use during this difficult period. It allows us to establish a relationship with the family, review family goals, and maximize any medications that they already have, or start medications for pain if needed going into the surgery. It allows us to review the imaging and make a regional anesthesia plan so that the family and the team feels confident when they go in for their surgery. Additionally, there's a specific focus on sarcoma surgery, and that program is called COPE, or Clinic of Oncological Pain Excellence, and that allows for a multidisciplinary team with the surgeon, anesthesia and pain, psychology, and physical therapy 1 month before the surgery. And then there's a second meeting 1 week before the surgery to review the imaging and the rescans again and make a final plan for pain management and regional anesthesia in that perioperative period. We also have a strong home catheter program that allows us to send kids home with an elastomeric pump, and they can have up to 2 pumps and go home. So if they have multiple peripheral nerve blocks, they can go home with these. And it's usually, we are focusing on extremities at this point. It has been interesting that the pandemic has actually helped us drive this initiative by promoting virtual visits, and these catheters can be removed virtually over a video teleconference. I want to thank you for allowing me to speak today. I feel passionate about regional anesthesia and cancer surgery. We do it safely here in Boston Children's Hospital, and I think we've talked today about the safety of neuraxial and peripheral catheters. They have a low rate of complication in infants, children, and adolescents. Ultrasound has increased the safety of regional anesthesia greatly. Antithrombotic therapy combined with regional anesthesia does increase the risk of bleeding, but should not preclude practitioners from providing safe and regional anesthesia options. So I hope that you will keep in mind that regional anesthesia and cancer pain go hand in hand. Thank you very much.
Thank you very much, Dr. Anjali, for giving us a very comprehensive review of how you would manage little D's case with regional anesthesia, and also your management of such cases for oncological surgery in your own institution. Unfortunately, many of these procedures, especially the invasive, the catheter management procedures, are not available in lower and middle income countries. And most of the anesthesiologists deal with such cases in a more conventional methods of pain management without catheters, without use of ultrasound and catheters. We hope that things will improve in future and we can learn a few things from you. Now, continuing with the little D's story. Her little D's fears were partially allayed, but "I trust you," said little D, "but will I still be able to feel my leg after everything? I'll miss it. And will I ever walk again?" So to answer little D's question, we would now like to invite Dr. Lai Ming Janice Ng, who's going to talk to us about phantom limb pain prevention and management. Let me introduce Dr. Lai Ming to you. She is a pediatric anesthesiologist and pain specialist from Department of Anesthesiology and Perioperative Medicine from Hong Kong Children's Hospital. She is also an honorary clinical assistant professor, Department of Anesthesiology, University of Hong Kong. She trained her subspecialty training in pediatric anesthesia and pain management from Boston Children's Hospital in USA, and also Royal Children's Hospital in Melbourne and at Westmead. She is an instructor for safe sedation courses for pediatrics, and she's an examiner of the Hong Kong College of Anesthesiologists. Her clinical interests include pediatric, acute, and chronic pain management, anesthesia, and sedation. Dr. Ng.
Nice committee give me the opportunity to share with you my experience in treating this complex chronic pain, the phantom and limb pain prevention and management. I have no conflict of interest to declare. In the following time, I will talk about background, information of the pain, and then the pharmacological and non-pharmacological treatments, in particularly highlight the work of the physiotherapists and occupational therapists. There are three major sensations may be described, that they can coexist or happens in isolations. For phantom limb sensations, by definition, is any non-painful physical sensations. They may come with various funny words, tingling, pins and needles, tickling, falls asleep, numb, itching, prickling. And the incidence is rates between 50 to 100% post-amputations. The descriptions about it also consist of some kinetic component. For example, the kids may report to you they still feel toe movement in an amputated foot. On the other hand, phantom limb pain is other sensations that consist of pain in the missing body parts, while stump pain is a localized pain at the site of amputations. Phantom limb pain prevalence can range from 48 to 90%. Again, like phantom limb sensation, the patients may report various funny words like throbbing, snapping, piercing, squeezing, tight, pins and needles, and generally it is much more uncomfortable than the sensation parts. And one characteristic of this pain is it is variable in durations. It can last from seconds to minutes to be constant. The frequencies can last from every day to every month to every week. The onset is also variable too. In some patients, it may happen in the first week post-surgery, while some may happen after months of operations, while the longest can happen like 1 year after the surgery. Unfortunately, this group of pain is usually moderate to severe, and there are observable gender difference. Boy is observed to have more physical triggers, for example, pumping or injuring of the amputated stumps may cause the pain, while for girls, there are more psychosocial triggers, such as meeting new people, taking a test, or feeling stressed. The duration is highly variant as well. For adults, it can last for years. The good news about children is it tends to resolve much more rapidly. And there's a small-scale study shows that by 1 year after the surgery, only 10 to 38.9% of children of the oncology group still reported the pain. So these are the list of those factors found to associate with increased incidence. Surgical amputations group, about 49 to 76% of patients reported of the persistent phantom limb pain, while if you compare with the congenital limb deficiency group, there's only 3 to 4%. Age is found to increase incidence of phantom limb sensation. However, its relations with phantom limb pain is not that strong. For cancer, the incidence is about 48 to 90%. It is very high. Chemotherapy, it is very interesting. It was found that for trial that receive neoadjuvant chemotherapy, the incidence can be as high as 74%, while those children who receive the chemotherapy only after the surgery, the incidence goes down to 44%. And in those groups of children that do not need chemotherapy at all, the incidence can be as low as 12%, which is dramatically lower. And for chemo agents, such as the platinum group, they can markedly increase the risk of peripheral neuropathy, which is another difficult to manage neuropathic pain. Other factors that is associated with higher incidence including burn, particularly electrical burn, severe and uncontrolled pre-amputation pain, and how bad is the post-op pain in particularly the stump area, and also the coping strategies the patients has been practicing. For example, a passive one such as catastrophizing is definitely of no benefits. Mechanism-wise, this is a heterogeneous, hardly understand and very complex pain. And the mechanisms has been described from the central nervous system at the supraspinal level to then down to the spinal cord and even peripheral nerve damage level. So basically, the whole nervous system pathway has been believed to be affected. Therefore, the treatment of these pain conditions has been complex, and basically we're using everything that are in our pockets to treat it. The current scientific evidence is still preliminary and limited by case studies, and there's no large-scale studies available. And we use multimodal for drugs and multidisciplinary for non-pharmacological agents. This is a very good slide extracting from the acute pain management of the ASPA publication. And you can see that for level 1 evidence drugs, there are morphine, gabapentin, ketamine, dextromethorphan. While for calcitonin, although it is also level 1, but it's more during the acute phases. Methods such as continuous regional blood and nerve sheath catheters, they also provide a good post-op analgesia, but there is no evidence of benefits of any preventions. Well-known treatment for cortical reorganization such as mirror therapy, sensory discrimination, motor imagery, and also epidural analgesia. Surprisingly, the level of evidence is only level 3. While other psychological factors such as anxiety is found to be a predictor of occurrence of phantom limb pain. Let's talk about the various agents separately. For adjuvant agents, gabapentin is a centrally acting anticonvulsant. There is mixed results of its efficacy in the adult population. The good news is that in the pediatric populations, there are some small-scale case series show that once a dose is able to achieve the therapeutic dose, namely from 20 to 35 milligram per kilogram, there will be a remarkable pain relief effect observed. tricyclic antidepressants. An example that's commonly used is amitriptyline, which is a sodium channel blocker. It's been utilized in pediatric populations, although the result in adult population is mixed again. But in pediatric, it finds that the dose, when it goes up high enough to like 25 to 50 milligrams, there are reported improvement in pain relief. Opioid, not surprisingly, can cause a good pain relief, and in adult population, it shows a 1-month regimen that able to treat the pain. However, long-term use after acute pain phases raise the concern of potential of abuse. Epidural catheters, not nerve blocks, not surprisingly, find to have a good analgesic effect in severe phantom limb pain. However, as mentioned before, we still cannot find any prevention benefits so far. And it was believed that it helps by the mechanisms of prevention of dorsal horn sensitization. The case series found that this catheter has to be stay for a relatively longer time, an average of 5 days, to show the benefits. Ketamine, also from one pediatric series, shows that it is beneficial to reduce the pain. However, the efficacy was not reported. Those non-pharmacological treatment, there are a lot of them. If you ask your physiotherapists or occupational therapists, they can name a lot much longer than you can see on this list. And some of them can be applied from the preoperative period or immediately post-op period, or in the subacute phase for the pain relief and even for the rehabilitation. So in the following time, I would like to demonstrate a case that my team has treated, that we have the input of various parties that help to manage a girl. So this is an 8-year-old girl with right femur osteosarcoma for right hip disarticulation. Her body weight was 25 kilograms. As you can see, the mass is so huge in distorting the underlying anatomy, and she has to have alternate day wound dressing, which you can imagine it's very painful, especially with the underlying bone fracture. So she has been put on morphine infusions, which is not enough, and we also supplement with agents such as pregabalin, tramadol, and paracetamol. And then she was sent for surgery. On the day of the surgery, it was done under general anesthesia with an epidural catheter inserted at L3 and 4 level. We continue the local anesthetic with fentanyl infusions over the epidural, and we supplement with anti-inflammatory agents such as paracetamol and coxib. There are opioid representatives by the buprenorphine, and the adjuvant agents, including the pregabalin and amitriptyline. As you can see that we have been escalating the dose of the oral drugs rapidly in the first few days of the treatment. The epidural catheter was kept until post-op day 6. And on day 8, the pain was 2, but goes up to 7 when the girl is moving. So it seems that even we pull everything we have onto her, the pain is still not satisfyingly controlled. And so we refer her to our occupational therapists and physiotherapists. So these therapists, while they start their work, you can see that they have made a magic that we are able to reduce the dosage of the pain agents, that the painkillers, rapidly. So first of all, we're able to take away the coxib on post-op day 9. And at week 4, we're able to stop the opioid and amitriptyline. The paracetamol is only need to keep for about 5 weeks. And pregabalin was stayed longest, has been stayed for around 9 weeks. After that, basically, she's not on any regular pain control. Although we leave her some as needed rescue opioids, but she actually rarely needed. This is a summary of the hard work of my occupational therapist, and I would like to highlight some of the treatments that is found particularly useful for her, from the mirror therapy to the massage to desensitization, pressure garment, desensitization again, gel matrix, gel pad, and horticultural therapy. They not only manage her physical needs, but also her psychological needs. So the mirror therapy is not a simple treatment that I imagined originally, just a mirror, a chair, and patient. It actually consists of various different stages. First of all, there are some basic motor exercise with objects. They playing around with a mirror like the first diagram. And then when you follow the arrow, you'll see that they will proceed to sensory stimuli with some rough objects, including their favorite toys, to stimulate them to bring back the sensation. And then at stage 3, they will start functional motor exercise with objects, which I will elaborate further in the following slides. And then on stage 4, they will gradually phase out the mirror, so their mental practice with and without the mirror. And then for those bright ones, they are able to go to the final stage, the optional one, to do the limb laterality recognition training. So again, this is a mirror with the left leg of the girl. You can see there are some colorful bells underneath her left foot, which are actually able to make some musical notes when they hit them. So this occupational therapists make the girls to play Mary Had a Little Lamb with her left leg with the help of the mirror on this bell. They are trying to combine fun and purposeful activities with the mirror therapy to her. Another thing is they take her to do the horticultural therapy to motivate her to raise from the bed and leave the room. Another highlight I would like to bring your attention is the tailor-made pressure garment and sponge padding. It serves multiple purposes, from desensitization of the surface to shaping of the stump, to prepare for fitness of the prosthesis, control of swelling, and prevention of hypertrophic scar. When we first refer the girl to our occupational therapist, on day 8, her pain score was reported 2. However, she's barely functioning. And they trained her to use the ultra pain scale, which is also from 0 to 10. And surprisingly, she was found to be in 10 out of 10 pain. And with this different pain scale, they're able to monitor the progress of her pain and suffering with the various treatments they do with her, and the pain score is able to bring down from 10 to a real 2 in 4 months' time. So how about our physiotherapists? They have been in the picture before the surgery. And they did a lot of work, from positioning to back mobility training, pain management, limb maintenance, chest optimization, and also psychologically in the preparation of the patient and family supports. In the immediate post-op periods, they focus on the management of the various sensations and pain, from stump pain to hypersensitive scar, phantom limb pain, and sensations. And then once the girl is able to leave the bed, then they try her on early sit-out and mobilization program. By week 2, the girl is already able to sit on this modified wheelchair. And actually, it is really difficult for her to go into a sitting posture after a hip disarticulation. This is a totally different posture. And then once the girl is able to leave the bag and wheelchair, they take her to the gym for early mobilization, exercise tolerance training, standing balance training. And by 3 months, she is already able to walk with assistance. So this is all of my presentations, and I would like to thank my colleagues in their hard work and also contributions of these slides. And in the following time, I will take any questions from the floor.
Thank you, Dr. Lee, for your talk on your thoughts on phantom limb pain, how to prevent, how to treat it. I think we'll have the question and answer session at the end after the next speaker has spoken. Is that okay with you?
Oh yeah, it's okay.
Dr. Lee, is that all right? Yeah. Okay. Right.
Okay.
Thank you.
It's okay for me.
Yeah. Okay. Can we have the next slide for Little D's story? Okay, we move on to the story after the surgery. And so little D made it through after all. It wasn't easy, and she had to be brave even when she wasn't feeling brave. Her parents too had to learn to be braver and stronger than they ever thought they would need to be. And together with her child's life therapist, physiotherapist, and occupational therapist, little D learned to walk again. Okay, for a talk on learning how to play again, we have 3 lecturers listed for this talk. First of these is Dr. Tanuja Nair. Sorry, not Tanuja, it's Miss Tanuja Nair. Miss, can we have the slide? Yes, Tanuja has been with KK Women's and Children's Hospital since 2007. She's a certified life specialist and children's recreational teacher. She works closely with the medical, nursing, and allied health professionals to support children, both 6 months to 12 years of age and adolescents, and their families through various challenging, painful, and complex hospital experiences. She has received several awards for her outstanding services. Before I call Tanuja to take the floor, let me briefly introduce her 2 other colleagues. The next colleague is Miss Melissa Yong. She's also from Singapore. She has been working as an occupational therapist in KK Women's and Children's Hospital since 2009 and is also a certified child passenger safety technician. She works closely with children and the families to help them overcome the effects of disabilities. She runs the seating clinic at the KKH Rehabilitation Center, and she also works closely with the Children's Pain Management Clinic to support children. The third person who's contributed to this presentation is Ms. Shin Hyu Eng, again from Singapore. She's a senior principal physiotherapist leading the musculoskeletal team in physiotherapy department at KK Women and Children's Hospital. She sees children of all ages and is actively involved in pediatric pain management and hemophilia multidisciplinary teams. She also oversees the gate services. With this, I invite Ms. Tanuja Nair to proceed with her talk.
My name is Tanuja, and I'm a child life therapist from KK Women's and Children's Hospital, Singapore, KKH for short. On behalf of my colleagues and co-presenters today, physiotherapist Ms. Shin Hui and occupational therapist Ms. Melissa, I'm here to share a little more on what it means for a child to learn to play again after a lower limb amputation. And this is coming from a rehabilitation perspective. Our presentation will comprise of the following components: a case study, an overview, and it will then move into 3 different phases of our intervention: pre-operative phase, acute post-operative phase, and transition planning. Before we begin, allow me to share a simple case study with you. It revolves around an 11-year-old girl who has a right proximal tibia osteosarcoma, and she was diagnosed with this in 2017. She had a relapse in 2020, and she had to undergo a right external hemipelvectomy, and thereafter the rehabilitation team was activated to support her through her journey. Here is an overview of how a case is typically managed in KKH. You have the medical team, the nursing team, the physiotherapist, occupational therapist, psychology, and CHAPS, which is the Child Life Art and Music Therapy program. The rehabilitation team in this presentation will primarily look at the physiotherapists, occupational therapists, and the child life therapists. Introduction to physiotherapy. Physiotherapist looks into human functions and movements with an aim to maximize the potential of an individual. In the area of pain management, the physiotherapists aim to reduce pain and restore function by prescribing suitable course of therapy through the use of varied techniques. Introduction to occupational therapy. Occupational therapy uses meaningful activities to help patients from all ages to prevent, reduce, or overcome effects of disabilities. In the area of pain management, an occupational therapist will assess and guide the person back to living life through the fullest through the use of goal setting, activity pacing, and some environmental adaptations, to name a few. Introduction to child life therapy. Child life therapy primarily focuses on the child and the family, where the focus is on helping the child to learn and understand what is happening to him or her in the hospital. The primary focus of this therapy is to help a child learn to cope with his experience in a more effective manner. The role of child life therapy in pain management comprises of the following: to nurture better cooperation during stressful medical procedures, to help elicit a more positive outlook and attitude towards pain management, and to normalize an otherwise daunting or challenging hospital experience. Child life therapists are trained and accredited professionals with an in-depth understanding of child development. Introduction to rehabilitation team and services. Communication among the interdisciplinary healthcare team, the patient, and the family is very essential. Early education and pain management will help restore mobility and functions faster and aim to return the child to play even earlier. The common rehabilitation goals after a major lower extremity amputation can be divided into the following phases: pre-operative, acute postoperative, and the transition planning phase. For the purpose of the intervention, we do look at the following 4 areas: early education, early pain management, restore mobility and functions, and to return to play. Let's now start off with the pre-operative phase. The key goal for this phase is to educate and empower patients with functional and emotional understanding. Optimal rehabilitation care of the amputee begins, and if feasible, prior to the amputation itself. For the occupational therapist, during this phase, the primary goal is to get to know the child and family better. Initial interview and assessments are conducted to help understand what exactly the home environment looks like, what is the child's functional status, and the different roles that the child may take on in this phase of life. Some examples of roles include being a child, sibling, student, or a worker. This allows the therapist to have an idea on some of the child's preferences and also to build rapport with the child and family. The therapist also makes use of the opportunity to introduce their services to the family and also share on how they can help post-operatively. This helps the family to be aware of what they can do and who they can approach if they have any queries later on. For the physiotherapist, the main goal at this stage is to conduct medical and physical assessments on the patient and to also provide some education, functional prognosis, and discussion about other complications such as phantom limb pain, and to also provide some realistic short and long-term goals to help alleviate fear and manage patient experiences and expectations. Next up is the child life therapies. During this phase, the primary goal is to help and to assess and improve the understanding about the child's condition and upcoming surgery. This is an important phase for the child because we would want to elicit some form of consent and assent pertaining to the upcoming procedure. It is important for this to happen because we would want to ensure that the child understands what's happening to his body and has time to process and make sense of medical and emotional experiences. During this phase, the following interventions can be provided: medical play, social play, and expressive play, where it provides them with an outlet to explore their big emotions in a safe and non-judgmental platform. Medical play is one of the interventions that the child life therapist might use. This is an opportunity for the child to concretize his or her experience and to express feelings and thoughts that he or she may experience. Social stories are also used to help introduce concepts slowly, and this can be paired with medical play to provide opportunities to reenact or rehearse anticipated steps. Grief exercises are also practiced so as to help the child to understand and acknowledge feelings and to provide him or her with an opportunity to express them. And that wraps up our presentation on the pre-operative phase. Next up is my colleague Xinhui, who will share a little more on the acute post-operative phase. Xinhui, please.
Thank you, Tanuja. Good afternoon, everyone. So we're going to cover on the acute post-operative phase, where here begins immediately post-op and continues until the patient is discharged from the acute care hospital. So the key goal at this stage is to provide pain management and encourage strength building, which is from a physical, mental, and emotional perspective. And as you can see, there are quite similar goals between the occupational therapies and physiotherapies and child life therapies at this stage, mainly focusing at pain management and restoring functions and of daily activities. Now, for occupational therapies, the goal is to facilitate the start of other pain management strategies on top of the pain medication that is going to be given by the doctor. Occupational therapy will also facilitate goal setting and encourage activity participation. And we will work closely with other members of the team to involve in the care of the child to ensure that the services provided are optimized. And when they are doing the occupation, the goal setting, they will come from a more client-centered approach, and hence the child is usually involved in setting the goals. This will empower the child to set goals and targets that they will be motivated towards, and a more positive and optimal outcome can be expected. And the goal setting process allows the therapist to understand the child and family concern a little bit more at this phase, and this will enable the therapist to facilitate the setting of more achievable goals in the recovery process. And in terms of the participation in functional activities, the occupational therapists will also encourage activity encouragements as early as possible, such as those activities of daily living like feeding, grooming, toileting, showering. And through this type of activities, it will build up to give them this endurance in the process, and then help to give them a bit of modification and assistance as they go along with more challenging tasks. Now, in terms of the assistive device here, they will also start to explore the suitability of the patient needs, and then introduce different devices with modification whenever the child is ready. And the trial may be arranged for the child to try on a wheelchair or commode with suitable accessories based on their needs. And for physiotherapy, the main goal at this stage during the acute post-op phase is mainly looking into regaining function and strength and range. So early mobility will also be important to help promote the limb maturation and promote wound healing. And as long as they regain their mobility as soon as possible, that will give them the increased confidence and a sense of well-being to promote their mental and emotional health. Okay, and that can be done by these three main categories, where we will focus in early mobilization, strength and conditioning exercises, and pain management. These are some of the pain management strategies that we will use during our rehabilitation process, such as biofeedback, asking patients to relax and do breathing techniques, therapeutic touch, such as massages and desensitization. So skin desensitization can help to decrease the hypersensitivity of the residual limb, and that includes activities such as gentle rubbing, tapping, gentle massages, introducing a little bit of soft tissue and scar mobilization when ready, and also exposure to tactile stimulants like using soft surface such as towel, cotton wool, cotton bud, or rough surfaces such as a rough towel or some sand or cold or hot or cold temperature kind of surfaces. Yeah, and also there will be one kind of pain management strategies that physio use, which is electric physical agent, such as cryotherapy, TENS, and ultrasound. So one of the common presentation that post-amputation patients may present will be phantom limb pain, which some of the techniques that we mentioned about the pain strategies can help, such as TENS, ultrasound. We can do stump massages and bandaging, desensitization and reprocessing, such as using mirror box therapy, and recently people are using immersive virtual reality to help manage this phantom limb pain sensation. Now for child life therapy, the focus at this acute post-op phase is coping with pain and dealing with the loss. Okay, and it's important to help the child to understand their current reality and find ways to adjust at a self-directed pace, such that they can they understand that they are in a protected space where the child life therapy endeavors to do at this phase of the patient's rehabilitation journey. So some of the therapeutic activities utilized at this stage will be medical play, which is mentioned earlier on by Tanuja, and some on-site procedural support, such as during dressing changes, they can decide, you know, and know the steps through. So which we're going to explore more after this. Okay. So, and when we do all these coping strategies, expressive play or supportive play, include we can normally do joint sessions together with the PD and OT. As you can see, there is some concepts and goals as interlinked to each of the therapies. And so we do a lot of joint sessions together at KK Hospital. So as mentioned by Tanja before, medical play and dialogue at this stage will be introducing the concept slowly, clarifying the misconception, and outline the steps and assign roles. And the coping strategies that we can use is called RAIN technique, where R refers to recognizing and putting thoughts and feelings into action. A, looking at empowering the child to be okay with these thoughts and feelings. And I is about investigating the root of the feelings and extensive self-compassion to oneself and the family. And N is about non-identification, and the child learns that having those feelings and thoughts is okay, but it does not mean that it is what it means and it defines the person. All right. And supportive play at a much later stage, towards the end of the therapy, will be engaging them in activities that they enjoy, such as, you know, like wheelchair basketball or chair yoga. Okay. And so next up, I'm going to hand over to my occupational therapist colleague here, Melissa Yong, to share with the rest of the presentation.
Hi everyone, I'm Melissa. So now we've proceeded to the transition planning phase, and it's also known as the community integration phase. So in this phase, the key goal is to actually help the patients resume their daily activities and actually to find a new norm for them to integrate to. So basically for the OTs is to help them to return to more daily activity tasks in the different settings that they usually attend to. For PT is to return to the various leisure activities and activities such as going back to school or, you know, household things that they need to engage in. And for the child life therapies, they are also involved in helping the child to cope with lifestyle changes, adaptations, set simple future goals, and also to manage expectations. For the child life therapies, their primary focus is at this point in time is to empower the child with more skills to cope with his new norm and to plan for the next phase post-discharge. This involves ensuring that the child understands and is clear and committed to his care plans, which can include multiple visits to the hospital for follow-up appointments. Alongside this, the topic of returning to community engagement, such as going to school and going out to explore and needs to be explored and strategized for accordingly to ensure that the child has planned for his transition in a gradual manner, which will elicit feelings of success. Planning and rehearsals are conducted so as to help the child to envision and anticipate challenges and how he might overcome it. So often, the child life therapist will pair up with the PTs or the OTs to have joint sessions so as to enhance the overall rehab potential. Yeah, so one of the intervention tools is that the child life therapist actually utilizes engaging in role plays and rehearsals to provide the child with the opportunity to practice. And this is done alongside with viewing of preparatory videos such as this.
Right.
Children, don't be shy.
To go through all this and she's got this far, I think she's amazing, aren't you? Yeah. Okay. You're okay. Yeah. Yeah. She's a superstar.
Yeah. So another tool that the child life therapist actually use is the emotion sensation wheel to help the child identify what constitutes to a feeling and how his body might react to the same emotions. The next one, also part of the therapeutic journey, is to use past conversations that will also be revisited based on the child's readiness and feelings, and thoughts once expressed will be explored with an emphasis on how they were okay to have and appropriate to experience. So for the occupational therapy in this transition phase, we actually focus on ensuring that the child is able to return to roles and activities that they are previously engaged in, or things that they want to actually engage in further. So one of this is looking at going home. So we actually consider the accessibility of the home and the equipment required. So we have conversations with the family and the child to actually discuss on what will be needed or what would need to be modified before the child actually makes plans of going home. In terms of going back to school, we will actually start off conversations with parents and family to see how comfortable they are for us to actually approach school to discuss on accessibility, the types of equipment required, and how to prepare the school to accept the child back and for the child to also prepare to return to school. For the physiotherapy, the main aim in this phase is to actually continue with strengthening, conditioning, and also for gait retraining. So the patient may actually go through prosthetic fitting and gait retraining in this phase. So at the end of the day, some of the take-home key points that we want you to actually take home with is actually to think of, not to be quick to actually over-normalize the child, to not minimize feelings at any stage, to allow them time and space to process, the loss, the changes, the having to adapt and to cope with this huge process that is going to be extended for quite a long time, and also to establish an open and supportive relationship from the beginning to facilitate a more effective and holistic healing journey. So now we have moved on the Q&A session and we'll take any questions from the floor.
Thank you, Tanuja, Shinhui, and Melissa. I think it would be very understated to say that a lot of the time, as anesthetists, we don't encounter the rehab therapists out on the wards unless we are the pain physicians who are going out on the wards to see them. So I think this would have been eye-opening for some people in the audience. We do have a few questions. Fazia, do you want to start off with some of the questions for Janice first, perhaps?
Yes, sure. Just to let the audience know that we don't have Dr. Anjali Koka with us from USA. She had the lecture recorded, so she won't be here, but we have the other 4 speakers. The question that has come for Janice is, what about the role of gabapentin?
Oh, sorry. I think Fausia might have accidentally dropped off the screen, but that's all right. I know the question. Okay, Janice. So I believe the question was, what is the role of pre-operative gabapentin? How much would you give and for how long? And for how long after an operation would you use it for before you decide to stop it? This is in the context of phantom limb pain.
Okay, thanks for the questions. So for me, I would like to start the gabapentin or the pregabalin as early as possible. Once I got the consultations from oncologists for a pain, usually there are some neuropathic components in this solid organ tumor. So the benefits of starting gabapentin is they have some opioid sparing effects. So I can lower the dosage of opioids the patient has to be on, and also we reduce the rate of opioid tolerance development. So for gabapentin, I will usually slowly titrate up the doses, so the patients can tolerate the drug as well. Probably I will increase the dose for gabapentin, maybe around 5 milligram per kilogram every few days. I will increase it until to a stage that the kid is feeling the pain is much better control, or they start to not able to tolerate the side effect. Then I will slow down a little bit. Usually for gabapentin, the effect may probably take around 2 weeks for it to sink in, while the another drugs pregabalin usually just take a couple of days for it to onset. So it really depends on your locality and your regional preference, which drugs you like more. Well, how long I would keep the drugs after surgery? So for the case I demonstrate, actually we have it to stay for 9 weeks. I think in some case we may have to have it even longer. It will be the drugs that I will stop last. I will try to wean off other drugs such as anti-inflammatory, opioid, the antidepressant, etc. As amount of these drugs, the gabapentinoid group they have less side effects. So, and also for phantom limb pain, this is a very strong component of neuropathic pain. That's why I would like to have these drugs stay at last. And if this case, for some case, they're not able to wean off, then I probably may titrate it down when the pain is getting better control. Then I may control it, I may slowly titrate down to a lower dose until the kid is ready to have it wean off. Sorry, I can't hear you. Angela, you're mute.
Sorry about that. Okay. Thank you for that. I'm just wondering, in terms of the gabapentin, if you've started it pre-operatively as a preventive, and in the post-operative period, the patient doesn't have phantom limb pain, and in the first week, the opioid usage has reduced, and the patient's quite comfortable. Would you then come off your gabapentin earlier?
Yeah, I will. Yeah, if but usually for the first week, even they don't have the phantom limb pain, they still have the stump pain and also the wound pain. So and usually if I started the drugs preoperatively, so for the first few days, I probably, okay, if the pain is not too bad, I probably keep it the same dose. But if it's okay, then I may try to wean it. If the kids can't tolerate that, then I will go back to the original doses.
Right, right. Okay. Thank you. Fauzia, we missed you there for a little while. I think your connection is a little bit choppy. Possibly still a little bit choppy. We do have another question for you, Janice. And this is with regards to patients who are on both gabapentinoids and opioids in the post-operative period. Do you see any issues with um, like sedation or respiratory depression in your patients?
So far, thank God, it's not much, and it's probably because we have been slowly titrating the drugs. And if I started the opioid or I escalate the dose of opioid, then I probably would not increase the dose of gabapentin on that day or on the same day. And you may notice that for the case that I present, although we use buprenorphine, which is an opioid, but however, as it is a partial agonist of opioid, so they have a ceiling effect on respiratory depressions. And so this is the side effect of opioid of these drugs is not as strong as other like morphine, etc. So the good about the The beauty about the regime that we use is we use epidural to take away majority of the pain, and then we rely much less on opioid.
Right. So that would be in line with what Anjali Koka had said earlier and what Dr. Sushma had said earlier in the day as well about reducing opioids as much as possible and using a regional anesthetic technique. Thank you. Is there a role for ketamine in the intraoperative or in the preoperative period, do you think?
Oh yeah, definitely. If the pain control gets difficult, then well, actually for some people, they may actually give a dose of like 0.5 milligram of ketamine at the beginning of the surgery, and before the conclusions of surgery, they may add another 0.5 milligram per kilogram of ketamine, and this may markedly improve the analgesic quality as well. And for some people, they may actually use like ketamine infusions intraoperatively. That's okay too if you're comfortable with the regime. And however, and if for post-op period, I'm lucky that this case has been smoothly handled. However, back in my mind, if there is anywhere that the pain get out of control or it's get very bad, if the case get like on heavy dose of opioid, etc., then I may consider a short course of ketamine infusion, which helps to bring down the opioid consumption.
Right. Okay, thank you so much. The next question we have is for Tanuja, actually, and the team. So we have a question on the chat that says, uh, does the child go through all three of these therapies at the same time? I'm going to assume that would be PTOT and child life at the same time, or separately, or in phases.
Okay.
Would one of,
Okay, I can help to answer for the team. Hi. Okay, I guess it really depends on the child's readiness at any point in time, also to have so many people coming in. We're very mindful about that also. I think at the onset, there are lots of things that are happening simultaneously, lots of things to process. So we also want to make sure that we're not introducing too many people, too many instructions, and overwhelming the child further than unless it's absolutely necessary. So yes, it can happen that we come in stages. It might happen like, every other day one person turns up. So we try to schedule it also so we don't, overtax the child too much. I would say it's really on a case by case basis. There are some kids whom we've worked with who love to have lots of company, different people to talk to. And there are some that are still adjusting. So we really want to pace and maybe take the direction from the child to see which would work best for him or her. Yeah,
right. So very, very child-centric, so to speak.
very much. Yeah.
Excellent. So Tanuja, in the ideal world,
Yeah.
when would the child life therapist first start to be involved in a child who was in little D's sort of situation?
So really depends on the team and the program that you would have. I would say ideally from the get-go, if the child already has some contact with a child life therapist, even from outpatient consults, even before coming into the hospital, there's been during the checkups, little D has already had a chance to meet the child life therapist, to get to know this person, then that is that constant companion whom she will see throughout her journey in the hospital. And that's really paramount in terms of rapport building, in terms of really being a companion with the child. So I would say in the ideal world, that's as early as possible. So even if you can't come in at an outpatient setting, maybe even at the point of admission, that's somewhere that's a great point to start the activation for the service, so that the child has time to build this relationship and this opportunity for the therapist to nurture that rapport and the relationship with the child. Yeah.
Well, I can attest to Tanuja's rapport. She's got pretty good rapport with most kids who meet her, and most adults, actually, I would say. So, Tanuja, if you were to say, could I just ask, do you know about, like, in the Asian region, is the profile of child life sort of on the rise, do you think?
Oh, yes, it is. I think we've got really a big movement over in Japan. Actually, they're really growing in size and in number. So that's really wonderful. And we do have like colleagues in Hong Kong, in Malaysia also. They've been like, communications of interest and stuff like that. So I think the child life profession within Asia is actually picking up and growing. So that's really wonderful to see and hear. I think psychosocial, the development of psychosocial services within Asia, that's still like a novelty of sorts. It's, to a certain extent, but to see where we are now. And to compare it like maybe 10 years ago, I think we've really made leaps and bounds. So I'm excited to see how it continues to, move in that direction. Yeah.
That sounds fantastic, actually. Um, there is a question for Shenhui. Shenhui, in the pre-operative period for kids who are in little D's sort of condition in her situation, what are some of the sort of simple pre-operative activities the child can be involved in, like to promote sort of a better outcome after surgery?
In terms of little D's situation, like before she was going for operation, we may look into the cardiorespiratory aspect in a sense, because that will be the most important to prevent complications. But however, we have situations where it depends where the phase of the patients that is being diagnosed, or when they are even which phase that they are listed at. So sometimes maybe preoperatively they already have some pain, they already have some range limitations or strength, then our focus will move towards that in terms of priority, rather than just cardiopulmonary kind of rehabilitation. So all in all, it's just really optimizing the child at that stage before they go for the operation, so that they will be in an optimal stage to recover after that.
Right, okay. Well, I think a lot of people would know what the physiotherapists do. Melissa, you're an occupational therapist, and I think sometimes when you talk to people outside of the profession, people have major misconceptions about what occupational therapists do, particularly with respect to pain management. So, what would you tell our audience, and yeah, to sort of address that?
I guess in terms of like pain management, I guess we really do quite differently from probably how some of our other colleagues in the different setting, what they worked with, and then probably also the scope of what we do. So we do a lot more in terms of goal setting. We do a lot more in terms of transition planning, looking at the different functional activities that might be affected because of the pain. As compared to maybe my colleagues who are doing more rehabilitation aspect of it. They do the more physical kind of work. So I guess whatever we do in pain management now is not really a widely known area. And it's also not an area where we also focus on. I guess when we see a patient at the end of the day, we still have to consider all the other aspects of functional status that they are in, and also then look at what is then prioritizing what is important at that point in time and the phase that they are in, and then deal with it at that point also. Yeah, from there then you get the buy-in from both family and the patient to then work towards the goal that they actually also want to meet. Yeah.
Right. Thanks, Mel. I think everybody here would have also worked with surgeons who were a bit less ready, or perhaps not as enthusiastic about rehab for their patients as they were about sort of trying to send the patients home to be more comfortable. I guess some surgeons would think that way. Is there something that any of you would like to tell, let's say, the surgeons out there about therapy and pain management and how it would make a difference to their patients?
I guess at the end of the day, it's not, I think what we're trying to show is it's not just one party that can manage the patient alone. I guess what we're trying to show is that it takes effort from everybody, regardless of what role you play when working with the child, whether you are the doctor, the nurse, or the therapist, yeah, so everyone plays a part, and I guess it'll be nice in terms of communication where everybody gets to know what's the plan for the patient and what's the goal for the patient, so that everyone works towards that same goal, and then at the end of the day you get that same outcome that we are all looking at, or what the family actually wants.
Well, thank you very much, Melissa, Shenhui, Tanuja, and Janice, for this afternoon session. I think between the four of you, this little D will indeed get to learn how to walk and to run and to play again, albeit with a new normal, as we all have to do, learn with the COVID being the way it is. We all also have a new normal, but we'll make it there. All right, so we've come to the end of today's track. Thank you very much for everyone who stayed with us, and thank you again to all our speakers. Have a good evening. Now, for those on this track who are involved with the inaugural meeting of the Pediatric Pain SIG, please do proceed on to the Zoom link that was emailed to you. That link will be open at about 4 o'clock or 4:15. Now, before we close for the day, I would like to remind everybody of the WHO guidelines for the management of cancer pain. So as you can see from this, this wasn't in pediatrics per se, but it was just a broad guideline for management of cancer pain. But there are 18.1 million cases of cancer a year, and 9.6 million deaths from cancer. And indeed, pain is present in 55% of patients undergoing treatment for cancer, and 66% of patients who have advanced metastatic or terminal cancer actually do experience pain. So please do be aware that in all our patients, even in little D's case, even without metastatic disease, they do undergo a significant amount of pain, and it happens at every point in their journey. So it starts from the point of presentation. So they could present with pain, or they could go through procedures in the hospitals and have procedural pain. And the treatment generally tends to be with opioids and or adjuvants, given the mixed nociceptive neuropathic pain that they have. Usually oral administration would be preferred, and it would be best if they were given on a regular basis by the clock rather than on demand. But the dose, of course, should be determined on an individual basis, because pain relief truly improves the quality of life in patients with cancer. So better results in terms of cancer pain and symptom management can be achieved when palliative care is introduced early in the course of illness. And palliative care truly is not about care only when the patient is going to die. Palliative care is not about losing hope or telling the patient that there is no hope left. Palliative care is really about prioritizing that quality of life and comfort despite the illness, despite the treatment the patient is undergoing. So in our local setting, and I think very much so in the Asian setting, parents and actually healthcare providers are very afraid of the term palliative care, because the presumption is that we are giving up hope on the child, but this should never be the case. So palliative care should be about the journey that the palliative team takes with the child to ensure the child remains comfortable throughout the course of their illness, throughout the course of their management, and throughout the course of them getting better or getting worse. It is hard. It is difficult because we are, I think, short on palliative care physicians, particularly in pediatrics. So it is also important that as pain physicians, we should be aware that perhaps this is a void that you could step into and a role that you could fill for these patients. So as pain physicians, our focus should not just be on the pain in the patient, but we should also be aware that there are other symptoms that add to the discomfort and the distress of the patient. And if you are so inclined, this could be something that you could do, because invariably parents and doctors are more willing to refer to a pain physician than they are to a palliative physician. So it's important that an approach that is tailored to each individual is adopted, together with disease modifying therapies to improve the quality of life in our pediatric patients with cancer. Thank you very much for staying with me throughout the whole track of today. We've come to the end of this story. I hope you all have enjoyed it, and that you'll remember the next time you have a patient who's come into the hospital that maybe they're not so different from little D after all. Thank you. Have a good evening, one and all, and we'll see you at the social later at 5:30.